Very good evening to all my dear viewers who have joined here for this wonderful session. Once again, the third part of the rheumatology and immunology discussion. And after completing the arthritis part 1 and part 2, today we are here to discuss systemic lupus erythematosus. I thank once again for ma'am for joining with us today, Dr. Rashmi ma'am. Thank you so much, ma'am, for joining with us. After completing a brief discussion in cardiology, now we are moving towards the completion of rheumatology. And I thank ma'am for joining with us and voluntarily helping lots of students, those who are preparing for the final year exam. Thank you, ma'am. And I hand over the session to you, ma'am.
Thank you so much. So we are now in the middle of rheumatology. So a few more topics, I think 2 or 3 more topics, and then we'll be completing rheumatology also. So after that, we'll have a test and discussion in rheumatology as well. So this systemic lupus erythematosus is a very, very important medicine case. You get a long case in that, as well as it's a very, very important essay question in your final year exams. So this is very, very important, and this will never leave you in whichever practice you have. I mean, even if you have surgical, even if you're doing surgery, or if you're doing gynecology or cardiology or nephrology, any department that you go, definitely this SLE will come forward with you. So it is very important to understand the basics of systemic lupus erythematosus. So let us continue. So what is SLE basically? It is a connective tissue disease, right? So what is it? It's a connective tissue disease, CTD. So it is one of the connective tissue diseases. And what is it? It is actually a chronic inflammatory state, right? It is a chronic inflammatory state and has systemic manifestations. It is a chronic inflammatory systemic autoimmune disease, right? It's a chronic inflammation. It has systemic features, and it is an autoimmune process, right? So in this, both B cells and T cells are getting involved, because of which the autoantibodies are formed. These autoantibodies form immune complexes and then deposit and cause the damage to happen, right? So this is a chronic inflammatory systemic autoimmune disease, okay? Chronic inflammatory systemic autoimmune disease. It is a connective tissue disease, systemic lupus erythematosus. So it ranges from mild to moderate to severe. That is a classification, mild to moderate to severe. And we all know that it has a female preponderance. But how much exactly? We say it is 9:1. It is more common in females than males in the ratio of 9:1. Can you name some more diseases where 9:1 ratio is found with female preponderance? Mainly we have primary biliary cirrhosis, then SLE, Takayasu arthritis, etc. Takayasu arthritis, right? So all these have 9:1 female preponderance. And though this can present in all the age groups, it is most commonly found in the 2nd to 3rd decade, right? It is most commonly diagnosed in the 2nd to 3rd decade. So this female preponderance, why do we say that there's a female preponderance? Because mainly SLE is estrogen driven, right? It is estrogen driven. So because of this, the females in the childbearing age are more commonly predisposed for this SLE, right? Females in the childbearing age are more predisposed for developing systemic lupus erythematosus, right? So it's a chronic inflammatory systemic autoimmune disease. It's a connective tissue disease which has B cell activation, which results in the formation of autoantibodies. It is primarily estrogen derived, so estrogen driven pathology. So what happens? It has a female preponderance with 9:1 ratio. It is similarly seen in primary biliary cirrhosis and SLE and Takayasu arthritis. The classification will be mild, moderate, and severe. And though it can be possible in all the ages, it is most commonly seen in the 2nd to 3rd decade. Okay? Yeah. So let's proceed with the pathogenesis. So for all pathogenesis, for all autoimmune processes, like we have studied rheumatoid arthritis also earlier, the first is we need to have a genetic predisposition. SLE does not develop in everyone. The patient should have a genetic predisposition first, initially. Then they should have some environmental factors which cause the second hit and thereby, cause the pathogenesis to happen. So what is the first thing? There should be a genetic predisposition. Genetic predisposition is very, very important. Among that, what are the most important genetic predisposition that we need to know about? What is the most important? Some few HLAs are very, very important. In that, HLA DR B103 and HLA DR B102. These are very, very important. HLA DR B103 and HLA DR B102. This HLA predominance is very, very important. This predisposes the patient to develop SLE, right? One more important thing is complement deficiency. Complement deficiency. Mainly, which complement are we talking about? We are talking about C1q, right? So we are talking about C1q. C1q deficiency causes the patient to be more predisposed to develop SLE or systemic lupus erythematosus. So this is very, very important. Then female gender. Female gender. So these are some of the important genetic factors which actually predispose the patient to develop SLE or systemic lupus erythematosus. Now moving on to the environmental factors. What are the most important factors that we talk about? Mainly UV rays. UV rays, because we know that systemic lupus erythematosus is the lesions are highly photosensitive, right? So the UV rays in the sunlight affect the patient. So UV rays are very, very important. Then infections. UV rays, infections, right? Smoking, vitamin D deficiency, hormone replacement therapy. All these are very, very important environmental factors which actually act as a second hit and actually continuing the pathogenesis, right? So first the genetic predisposition should be there. Then the environmental risk factor should also be present. So what happens when both are there? What happens when both are there? You have an abnormal immune response. Abnormal immune response happens. So what is the abnormal immune response which happens? Antigen is presented to the antigen presenting cell, which is the dendritic cell. What happens because of this? That B cell is getting activated and the T cell is also getting activated. The T cell in turn activates the B cell, because of which what happens? Antibodies are formed. Because of which what happens? Antibodies are formed. Simultaneously, what happens? The complement system is also activated. C3 is getting converted to C3a. Because of all this process, the immune complexes are formed. These immune complexes cause an amount of inflammation to happen. But when this becomes very chronic, it causes damage. The organs are affected. When it's a chronic inflammatory state, what happens? The damage is caused. So a little bit in more detail, we saw the genetic factors as well as the environmental factors. So what happens because of the immune cell activation? Immune cell activation occurs. Because of that, there are increased pro-inflammatory cytokines. What happens? The cytokines are pro-inflammatory cytokines are more in number. So which cytokine is mainly involved in this? It is mainly interferon gamma. Mainly the interferons are very, very important, right? Interferon is very, very important in this pathogenesis. Okay, so the pro-inflammatory cytokines are increased in quantity. So because of that, few other cytokines are decreased in number. So what happens because of that? Interleukin-2 and TGF-beta are reduced. The interferons and TNF-alpha are increased, whereas interleukin-2 and TGF-beta are decreased. Right? You need to remember this. These two are increased, whereas interleukin-2 and TGF-beta are decreased. What happens because of that? There is sustained production of antibodies. Sustained production of antibodies and immune complexes are formed. Once the immune complexes are formed, what happens? They go and bind to the target tissues. They go and bind to the target tissues. Because of that, what happens? The complement activation happens. C3 is getting converted to C3a. C3 is getting converted to C3a. Because of that, what happens? Again, there is a cytokine release. Cytokine release, vasoactive peptides are released, proteolytic enzymes are also released. What does this do? This goes and activates the endothelial cells, tissue, macrophages, etc. This causes a chronic oxidation and inflammatory response. This causes a chronic oxidation and inflammatory response. Right? This causes a chronic oxidation and inflammatory response. This causes irreversible tissue damage, thereby causing fibrosis and sclerosis in the tissues. Okay, fibrosis and sclerosis in the tissues. So what happens? A few cytokines are increased in quantity and a few cytokines are decreased. Mainly the interferons and TNF-alpha will be increased, whereas interleukin-2 and TGF-beta will be decreased. Because of that, the antibody production will keep on increasing, immune complex formation will increase. This will go and bind to the target tissues, complement will get activated, the cytokines will be released in more quantity, this will activate the endothelial cells, tissue macrophages, etc. This will propagate the pathogenesis and will cause chronic oxidation and inflammation, thereby causing irreversible tissue damage. Right? It will cause irreversible tissue damage. So this is very, very important. This pathogenesis you need to understand. This is very, very important. We need to know this because the drugs are directed against these pathways. Okay, so this is very, very important. Yes. So moving on to the most high yield topic in this, subtopic in this topic, I would say. So what are the autoantibodies in SLE? This is very, very high yielding. This is taken directly from Harrison only. So this table you need to know by heart so that it will benefit a lot in the exams. Okay, in MCQs, it will be very, very helpful. So it is very, very high yielding. I would like all of you to pay some attention here. It's a very busy slide, but it is very easy once you start understanding it. I will highlight the important points in this. Okay. So first of all, let us talk about ANA, right? Anti-nuclear antibodies, ANA, anti-nuclear antibodies. It is highly prevalent. It is seen about 97 to 98% in patients with SLE. It is a very, very good screening tool. It is a very good screening tool, but it is not very specific. There are some false positives which can also happen, right? So it is a very, very good screening test, but it is not very, very specific, right? So how do we actually do this test? We can do this by indirect immunofluorescence. Indirect immunofluorescence is the technique by which we identify the anti-nuclear antibodies. See, these antibodies are directed against the nuclear material in the cell, right? It is directed against the nuclear material in the cell. So what happens once we stain with the fluorescent dye, this indirect immunofluorescence, what happens? There are few patterns which are formed. Okay, there are few patterns which are formed. So a few important things that you must remember here. The first one, what is the first pattern? Homogeneous pattern. When it is homogeneous, then it is anti-dsDNA. Double stranded DNA, anti-double stranded DNA, right? If it is speckled or granular, I have some pictures, I'll show you those pictures also. So when it is speckled or granular, what is it? Anti-Smith antibody or it is anti-RNP antibody. All these are likely. When it is speckled or granular, all these are likely. Then the third one, nucleolar. When it stains the nucleolus in the cell inside the nucleus, when it stains the nucleolus inside the nucleus, what does it indicate? It is anti-SCL70, anti-scleroderma factor, or the anti-RNA polymerase 3, anti-RNA polymerase 3, right? What is the fourth pattern? Centromere. When it stains the centromere, it is anti-centromere antibody, anti-centromere antibody. Right, anti-centromere antibody. So these are the few important patterns that you need to remember. Homogeneous pattern, speckled or granular appearance, when it stains the nucleolus and the centromere. Right, these are important things that you need to remember. So what have you learned about the ANA? It is present in 97 to 98% of the patients with SLE. It is a very good screening tool, but it is not very specific. Right, once a patient is having ANA positivity, we cannot say that the patient is definitely having SLE. There are some other diseases also which cause ANA positivity. You must remember that, right? It's a very, very good screening tool. Then indirect immunofluorescence is the technique by which we detect ANA. So once ANA, we have some patterns that you need to remember: homogeneous pattern, speckled pattern or granular pattern, nucleolar pattern, and the centromere pattern. Okay. Only when the ANA is positive, you can actually classify the patient to be having as SLE. If the ANA is negative, but the other factors are positive, even then you cannot consider it to be SLE. So first, to include it under the diagnosis of SLE, first thing, the patient should have ANA positivity, right? ANA positivity is very, very important. Next. So what is written here? It's a very good, best screening test. Best screening test. Repeated test, repeated negative tests make SLE unlikely. Okay. So if it is repeatedly negative, then SLE can be ruled out. Right. So next we go on to anti-dsDNA, double-stranded DNA. So what is this? It stains the antigen, which is the double-stranded DNA. This is very, very specific. This is very, very specific. Anti-Smith antibody and anti-dsDNA antibody are very, very specific to SLE. So anti-dsDNA is seen in about 70% of the patients. 70% of the patients it is found, and it is highly specific. You can see here it is SLE specific. And some patients, most patients, it actually correlates with the disease activity. It correlates with the disease activity. Mainly, it correlates with nephritis. Mainly, it correlates with the lupus nephritis. Okay, so next is anti-Smith antibody. It is seen in very less population, like around only 25% of the SLE patients have anti-Smith antibody. So this is very, very specific for SLE. This is specific for SLE. There is no definite correlation, but this is very, very important. Okay, anti-Smith antibody, if it is present, then definitely it is SLE. So anti-dsDNA and anti-Smith antibodies are very, very specific for SLE. Right? Yes. So next we move on. Anti-RNP antibody. Anti-ribonucleoprotein antibody. This is not specific for SLE, but high titers will be associated with overlap syndromes with SLE. Okay. There are few diseases which overlap with SLE. In those patients, you can have anti-RNP antibodies. The other important ones are anti-Rho and anti-La antibodies, which is SSA and SSB antibodies. Okay, this is seen in Sjogren syndrome also. So these are not specific for SLE, but when anti-Rho antibody is present, you can have neonatal lupus, right? Neonatal lupus. Neonatal lupus is present in patients with anti-Rho antibody positivity. So this is the importance of anti-Rho antibody. Anti-Rho antibody, it has an increased risk of neonatal lupus. So what is the main feature of neonatal lupus? Congenital heart block, complete heart block. Okay, complete heart block is a feature of neonatal lupus. So you need to remember this: anti-Rho antibody, neonatal lupus. Anti-La antibody also. Okay, anti-Rho antibody, neonatal lupus. ANA is a very good screening test. Anti-dsDNA, anti-Smith are specific. Anti-RNP is not specific for SLE. It is seen in overlap syndromes. Anti-Rho antibody for lupus, neonatal lupus. Then moving on to anti-histone antibodies. Anti-histone, you need to remember, it is seen in drug-induced lupus, right? Drug-induced lupus. So anti-histone antibodies, drug-induced lupus. Moving on to antiphospholipid antibodies. These are not mainly for SLE. This is not specific for SLE, but these are a separate set of antibodies which are actually can be seen in patients with SLE also. But these fall into a separate syndrome called antiphospholipid syndrome, which we will be seeing later. So antiphospholipid antibodies, these are very, very important. You have three types of antibodies in this, which you must remember. So antiphospholipid syndrome, antiphospholipid antibodies will be present, right? Then moving on to the next one, anti-erythrocyte antibody. This targets the erythrocyte membrane. These patients in SLE, they have hemolysis. If the erythrocyte antibody is present, then the patient can develop hemolysis. So what is this called? Autoimmune hemolytic anemia, right? Autoimmune hemolytic anemia. So what autoimmune hemolytic anemia? It is warm autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia. So this is very, very important. Warm antibody mediated autoimmune hemolytic anemia. Okay. So next is antiplatelet antibodies. Once this antiplatelet antibodies is present, then the patient will have thrombocytopenia. So what do we call this as? This is secondary ITP. This is characteristically called as secondary ITP. The patient will have thrombocytopenia. Next is anti-neuronal antibodies. Anti-neuronal antibodies. This will be active in some patients with CNS lupus. Anti-neuronal, you can remember inside the neurons. So you can call it as CNS lupus. It is seen in patients with CNS lupus. Right? Anti-ribosomal antibody. This is also very, very important. It correlates with CNS lupus. But mainly among that, it is very, very important in patients who have depression or psychosis due to CNS lupus. Depression or psychosis in patients due to CNS lupus. So this is very, very important. Anti-ribosomal P antibodies, depression or psychosis with CNS lupus. Okay, let's revise this very, very high yielding slide. So ANA is a very, very good screening test, right? It is seen in about 98% of the patients. There are a few patterns that you must remember. Then anti-dsDNA, anti-Smith are very, very specific for lupus. Anti-dsDNA is correlating with disease activity. Then anti-RNP is seen in mixed connective tissue disorders. Then anti-Rho and anti-La antibodies are also very, very important. They're seen in Sjogren syndrome as well. But when the presence of anti-Rho antibody is there, it indicates that the patient is having, you can have neonatal lupus. Okay. Then anti-histone antibodies are implicated in drug-induced lupus. Antiphospholipid antibodies, antiphospholipid syndrome, anti-erythrocyte antibodies, autoimmune, warm antibody, and autoimmune hemolytic anemia. Hemolysis will be there. Antiplatelet antibodies causes thrombocytopenia, which is essentially secondary ITP. Then anti-neuronal antibodies, CNS lupus, anti-ribosomal P antibodies, CNS lupus, especially depression or psychosis due to CNS lupus, right? So this is very, very important. So I was talking about the patterns, right? So here, this is the diffuse or homogeneous pattern. Homogeneous or diffuse pattern. This is seen in anti-DS DNA antibodies or anti-histone antibodies. Anti-DS DNA antibodies or anti-histone antibodies. Speckled or granular pattern, it is seen in anti-RNP. It is all these things. Anti-Smith antibody, anti-Rho, anti-LAM, anti-SCL70 and anti-Jo1. All these are showing speckled or granular appearance. You can see here there's a ... these kind of things. This is speckled or granular appearance. So nucleolar, when it stains the nucleolus inside the nucleus, so this is seen in anti-SCL70, anti-RNP and anti-RNA polymerase 3, right? Then anti-centromere antibodies. Yes, this is the staining, right? This is the indirect immunofluorescence. Indirect immunofluorescence. You must remember this technique also. Okay? Yes. So what are the other investigations you must remember in these patients? Like all chronic inflammatory diseases, the ESR will be elevated, right? ESR will be elevated. Next, the CRP will either be decreased or normal. It will not usually be very high like we expect it to be. It will either be decreased or it will be normal. Then we have already seen the antibodies. All the antibodies, including ANA, anti-neuronal antibodies, all these are very, very important. All the antibodies that you must keep in mind. Next, what about the complements? The complements are getting utilized in the formation of the immune complexes and because of the activation. So the complement levels will be less. Complement levels will be less. Then you have the ANA profile or the ENA profile. So whatever the antibodies we studied previously, these are the anti-ANA or the ENA profile, right? Then what is the other test that we will be doing? Renal biopsy. Renal biopsy, this is very, very important. We'll come to this later, but you need to remember that these are some of the investigations that we do in patients with, SLE. One more most important thing, urine routine. Urine routine should definitely be done for all the SLE patients at every visit. You call them every month, then you have to do a urine routine every month. Urine routine and CBC are a must every month because you need to keep a very, very keen watch and look out for proteinuria at the earliest, right? So urine, CBC, complete blood count, urine routine, ESR, CRP, antibodies, complements, ANA, DNA profile, and renal biopsy if indicated. Okay, so these are very, very important. Yes. So moving on to the most important part, which is manifestations. Before we move on to this heavy slide, the most important manifestation, when do you suspect SLE in a patient? The first thing is it's a young childbearing age group woman who is having some some constitutional symptoms, right? The patient will be having constitutional symptoms, right? Like fever, especially pyrexia of unknown origin, a long fever for which we are not able to identify the cause. Tiredness or fatigue, fever, fatigue, myalgia, right? All these are very important. The constitutional symptoms will be there. Along with that, you have some more manifestations. Okay. So what are the dermatological manifestations? The patient will have a butterfly rash. So what is so characteristic about this butterfly rash? It is also called a... What is this also called? This is a macular rash. Macular rash. It is present on both the cheeks and does not involve the nasolabial fold. It spares the nasolabial fold, right? It spares the nasolabial fold. This is very, very important. It spares the nasolabial fold. What is the most important characteristic of this? This is photosensitive. This is photosensitive, right? We need to remember this butterfly rash. The rash of SLE is photosensitive. Okay, so it's a macular rash. It spares the nasolabial fold and it is seen in most commonly in all the patients. And it is photosensitive, right? It is non-disfiguring. It is not erosive. It is not going to, scar the skin underneath. This is a very macular mild rash which is seen in these patients. Okay, they can also have discoid lupus. They can have some paniculitis. Other non-specific findings will be alopecia, vasculitic skin lesions, purpuric lesions, livedo reticularis. Coming on to the CNS lupus, the patient can have just migraine. They can have seizures. Headache is the most common feature. And along with that, they can have depression, like I already told you. Psychosis can be there. The patient can also have seizures. Okay. Then renal involvement can be there. We'll discuss all these in further more detail. Okay. Renal features, you can have proteinuria. Proteinuria is most important. Proteinuria, then you have indicate that the patient is having lupus, SLE, lupus nephritis. So renal involvement, gastrointestinal, these are mainly non-specific symptoms. The patient can also have autoimmune hepatitis, right? Hematological manifestations, we already studied that the patient can have anemia because of hemolysis. The patient can also have anemia of chronic disease. We already saw thrombocytopenia can be there. Autoimmune hemolytic anemia can be there. All these are hematological findings. Musculoskeletal, arthralgia, arthritis, tenosynovitis, all these are very, very important. Mainly myalgia will be there. Arthritis and arthralgia are very, very commonly associated with SLE. Then cardiopulmonary. Pulmonary manifestations, there will be serositis. So you will have pleural effusion, pleuritis. In cardiology, cardiac manifestation, pericarditis, again serositis will be there. But for SLE, dermatological manifestations, constitutional manifestations, dermatological manifestations, musculoskeletal manifestations are the most commonly involved. Okay, the first at diagnosis, mostly only these three will be involved, and gradually all the other complications will start to develop. Okay, yes. So let us see some of the photos so that you remember it very nicely. So this is the malar rash, right? This is the malar rash, right? You can see very well that it is sparing the nasolabial fold, right? It is sparing the nasolabial fold. So it is sparing this nasolabial fold. This is highly photosensitive. Yes, and it is not scarring. But there is some scarring here that you can see. This is a discoid lupus lesion. This is a discoid lupus lesion. This is a discoid lupus lesion. So 20% of patients with SLE may have discoid lupus, right? 20% of patients with SLE will have discoid lupus, but only 5% of patients with DLE will have SLE. So discoid lupus is a separate entity, so as to say, patients with SLE can have discoid lupus, but only 5% of patients with discoid will have SLE. Okay, so what you need to remember about this malar rash, it is photosensitive and it spares a nasolabial fold. Right, this is very, very important. Photosensitivity is very, very important. Discoid lupus will be scarring. Right. So we saw some of the other things. Alopecia, right? Alopecia. Alopecia in SLE, you can see here, it is non-scarring. You can see here, it is very, very diffuse and non-scarring. It is non-scarring. Whereas in discoid lupus, the alopecia will be scarring. Scarring alopecia in discoid lupus. Scarring alopecia in discoid lupus, whereas it's a non-scarring alopecia in systemic lupus. So the dermatological manifestations will be mainly, what it is it? Malar rash, discoid rash, then alopecia, non-scarring in SLE and scarring alopecia in DLE. There is one more entity which is called subcutaneous lupus erythematosus, SCLE, right? This is SCLE. Subcutaneous lupus erythematosus. You can see it is more widespread. These are more widespread lesions involving the entire chest. It can involve the entire body, but mostly the chest and back are involved. Upper extremities, chest and back are more commonly involved. You can also have some oral ulcers. Oral ulcers are very, very common, right? Oral ulcers are very, very common. There are some more findings which you can have. You can have recurrent panniculitis or something called lupus profundus. These are also skin lesions. So in the skin, what are all seen? Malar rash, discoid rash, subcutaneous lupus erythematosus, oral ulcers. Then you have alopecia, which is non-scarring in SLE, scarring in discoid lupus erythematosus, right? So these are all the important ulcers and the dermatological manifestations. Okay, yes. So I told you after the dermatological manifestations, the second most important one is musculoskeletal manifestations. So among that, musculoskeletal. So it's a non-erosive arthritis. SLE will have a non-erosive arthritis. Right. Joint deformities are quite rare, but it is still possible. When we already studied this in the rheumatoid arthritis chapter, when there is a combination of rheumatoid arthritis, when the patient is having both rheumatoid arthritis as well as SLE, that is called lupus. Okay. So when the patient is being treated with long-term steroids for suppressing the immunity in this autoimmune disease, what happens? The patient can also have avascular necrosis of the bone. Avascular necrosis of the bone can also happen. So most importantly, what is it? It is a non-erosive arthritis. Joint deformities are quite rare, but still possible. Then if rheumatoid arthritis is associated along with SLE, then you will have lupus. Then the long-term complications of steroid treatment are avascular necrosis of the bone. Right? These are all very, very important points that you need to remember. Then moving on to the vascular complications. What are the vascular complications? So Because of this autoimmunity, what happens? The patient has an accelerated atherosclerosis. Atherosclerosis will be increased. Atherosclerosis will be increased. So because of this, what will happen? The patient is more predisposed for TIA, stroke, or MI. So the patient is more predisposed for developing transient ischemic attack, stroke, or MI. This is not exclusive to SLE, but is more accelerated and seen in SLE. Right. So when SLE is associated with APLA syndrome, or the patient is having APLA syndrome as such, antiphospholipid antibody syndrome, then the patient is having a hypercoagulable state, because of which there can be more thrombosis and causing more vascular complications to happen. But in chronic SLE, you will see there is an accelerated atherosclerosis. So what happens? There can be a non-inflammatory occlusion can be there. A thrombotic occlusion can be there. Thrombosis can be there. But because of there can be one more manifestation. It could be because of vasculitis. There could be vascular inflammation, because of which the patient is developing these vascular complications. So one complication is thrombosis, and the second manifestation will be vasculitis. So the patient can have all these risk factors, develop all these complications because of either thrombotic complications or because of the patient having vasculitis. Okay. And the source can be from the carotid artery or from the endocarditis, which we will see later. Okay. So these are the vascular complications which the patient can develop. Next, pulmonary. There is something very interesting in this. This is called the shrinking lung syndrome. Right. But before we go on to shrinking lung syndrome, what is the most common manifestation of pulmonary manifestations? The most common is pleuritis, and this is the most important because serositis is very, very commonly seen. Serositis is very, very commonly seen. You have mucositis, like oral ulcerations, then pleuritis, you have pericarditis, you have myocarditis. Serositis is very, very commonly seen in systemic lupus erythematosus. So the first one, it is not shrinking lung syndrome, which is most common, but it is pleuritis followed by pleural effusion. Pleuritis followed by pleural effusion. Okay. And these respond to NSAIDs. There is something called shrinking lung syndrome. Right. What is this shrinking lung syndrome? What happens is, this is not very specific to SLE. This can be seen in other conditions also. But what happens in the shrinking lung syndrome? You will see that the lung volume keeps on decreasing on the X-ray. What happens? Right. So on X-ray, this diaphragm will be elevated to this extent. On either side, on one side, any side which is involved. Okay. And you have a triad of dyspnea, elevated hemidiaphragm, and restrictive defect on pulmonary function test. Restrictive defect. So what do you expect? Usually when you have this kind of obstruction kind of feature, but you expect the pulmonary function test to show obstruction. But on the contrary, the patient will be having a restrictive defect on the pulmonary function test. Okay, so this is called shrinking lung syndrome. On serial exercise, if you take you will feel that the lung is shrinking in quantity. Okay, this is not specific for SLE, but you have a triad of dyspnea, elevated hemidiaphragm, and restrictive defect on the pulmonary function test. So this is very, very important. Right? So this is very, very important. You need to remember, but the most common pulmonary manifestation is definitely not shrinking lung syndrome, but it is pleuritis. It is pleuritis followed by pleural effusion. Okay? Yes. So pleural effusion we have already seen in rheumatoid arthritis also. Rheumatoid arthritis also, as well as SLE also, the patient can have pleural effusion. So how will you differentiate between these two? How will you differentiate? So you have to do what is called pleural fluid glucose, right? Pleural fluid glucose. You need to do pleural fluid glucose in these patients. So what do you expect in these patients? In SLE, the pleural fluid glucose will be normal, whereas in rheumatoid arthritis, the pleural fluid glucose will be low. Okay? Because the patient will have constitutional symptoms, they can have also arthritic symptoms, and the patient will present to you with pleural fluid, pleural effusion. So in that case, when you have to differentiate between rheumatoid arthritis lesions or SLE lesions, then what you should do? You should do a pleural fluid glucose. It will be low in rheumatoid arthritis, whereas in SLE it will be normal. Okay, this point you need to remember. Right. Let's move on. So now coming on to the cardiac. I told you the first thing, pericarditis, serositis. Right? Serositis is very, very important. Pericarditis is the most common presentation. You can also have endocarditis, myocarditis also. First, most common is pericarditis. You can also have myocarditis as well as endocarditis. You have something called Libman-Sachs endocarditis. These are sterile vegetations on the undersurface of the valves. The valve is like this. Then you have on the undersurface, you have ligament sacs endocarditis. These are sterile vegetations on the undersurface of valves, right? These can complicate and cause vascular complications, right? This is called ligament sacs endocarditis. Okay. So in this, it can cause valvular incompetence because of the endocarditis. So what valvular incompetence is most common? Here, MR is more common than aortic regurgitation. Mitral regurgitation is more common than aortic regurgitation. This you must remember. Mitral regurgitation is more common than aortic regurgitation. And as I already told you, there is an increased risk of cardiac complications like MI because of increased atherosclerosis. Because of the accelerated atherosclerosis, there is a risk of MI, right? This endocarditis causes valvular incompetence. It can also cause embolic events, right? Yes. So pericarditis, myocarditis, endocarditis. Among endocarditis, it is ligament sacs endocarditis, which has sterile vegetations on the undersurface of the heart valves. This can cause valvular incompetence. It can also cause embolic events. Valvular incompetence, mitral regurgitation is more common than aortic regurgitation. There is an increased atherosclerosis with the risk of MI, right? Yes. Next is CNS lupus. So in CNS, I told you which are the two antibodies that you must remember. Among that, the most important one is anti-ribosomal P antibody. Anti-ribosomal P antibody, which is is seen in patients with depression or psychosis in CNS lupus. Right. So depression or psychosis. This psychosis can either be because of the SLE itself, the lupus, CNS lupus itself, or it can be because of long-term glucocorticoid given intake. So when you're giving steroids to the patient to treat the SLE, what happens? The patient can go on and develop. You already saw avascular necrosis of bone is a complication of glucocorticoids, long-term glucocorticoids. Again, here, glucocorticoid-induced psychosis is also another complication of long-term steroid intake. Okay, but the most common neurological manifestation will be cognitive dysfunction. Cognitive dysfunction is the most common, and the second one will be seizures. The patient can also have psychosis, which is SLE psychosis or glucocorticoid-induced psychosis. We need to differentiate between the two. Right? Yes. Next is hematologic manifestations. So the most common is anemia, I told you, especially anemia of chronic disease. You can also have hemolysis, anti-erythrocyte antibodies. Which response, this is autoimmune hemolytic anemia, warm antibody type, right? Warm antibody type of autoimmune hemolytic anemia. You can have lymphopenia and thrombocytopenia. This point of lymphopenia is very, very important. This is how we differentiate between a lupus flare and an infection, which will come later. So that's how we differentiate between lupus flare and infection. When there is an infection, you expect to see lymphocytosis. The total counts are elevated. Whereas in hematologic manifestation of lupus, you have lymphopenia, thrombocytopenia, anemia. There's almost pancytopenia, which is found, right? So this is very, very important. Thrombocytopenia, secondary ITP. Antiplatelet antibodies, anti-erythrocyte antibodies are implicated in this, right? Antiplatelet antibodies and anti-erythrocyte antibodies are implicated in this. Next, moving on to the GI manifestations. So GI manifestations, I told you they're mainly non-specific findings. Nausea, vomiting, diarrhea, abdominal pain, all these can be there. Apart from that, when there is a flare, you will have increased liver enzymes. You can also have autoimmune hepatitis, right? You can also have autoimmune hepatitis. This is very important. You can have autoimmune hepatitis. Okay. Ocular manifestations, I must tell you, the first thing you will always remember when you see an ocular manifestation in a connective tissue disease, you will immediately go and write the answer as uveitis. But uveitis is not seen, right? Uveitis is not seen in patients with SLE. You will find a SLICC syndrome. You will have dry eyes with these patients. Okay. So you will have SLICC syndrome. Secondary Sjogren's can also be there. Secondary Sjogren's can be there in these patients. You will have a SLICC syndrome. Or you can have retinal vasculitis. You can have retinal vasculitis. Uveitis, like in rheumatoid arthritis, it is present in rheumatoid arthritis, but in SLE, uveitis will not be a manifestation. You need to remember that you will have SLICC syndrome or secondary Sjogren's syndrome and retinal vasculitis, but uveitis will not be present. Okay. Yes. So we discussed almost all of the symptoms, but the most important one, I've saved it for the last, which is renal. Renal complications are very, very common, and it is very, very important for you to know this because MCQs are most commonly based on the renal manifestations of lupus erythematosus, right? So renal complications are very, very important. So among the SLE patients, around nearly 50 to 60% develop lupus nephritis. Lupus nephritis. Around 50 to 60% of patients will develop lupus nephritis, right? Lupus nephritis. So most common presentation is nephritic syndrome, where you will have proteinuria. Proteinuria is most important, and microscopic hematuria, plus or minus microscopic hematuria. So proteinuria is must, microscopic hematuria can be plus or minus. So nephritic syndrome is the most common presentation. What happens if you leave it untreated? It will go on to increase, and based on the class of the lupus nephritis, the patient can present with a nephrotic syndrome also. Initially, we call it a nephritic syndrome, but the patient can progress to a nephrotic syndrome based on the class of lupus nephritis. Okay, so it can present as lupus nephritis, and the patient can also develop hypertension. Or in few patients, you can have a rapidly progressive glomerulonephritis. The patient can first come to you with a creatinine level of 2. Suddenly, the patient may be maintaining at a level of 2 with CKD, but suddenly the patient will develop creatinine increased up to 8. So it's an RPGN in say a few weeks, right? So it's called a rapidly progressing glomerulonephritis with proteinuria or microscopic hematuria. So this is very, very important. They can present as nephritic syndrome, nephrotic syndrome, hypertension, or rapidly progressive glomerulonephritis. So this is very, very important. All these manifestations can be there. So how will you find out what class the patient belongs to? For that, I told you renal biopsy should be done. Renal biopsy should be done. So what should we look for in a renal biopsy? What should we look for in a renal biopsy? In a renal biopsy, when should you do a renal biopsy? Basically, when the proteinuria is more than 1 gram per day, or the proteinuria is more than 500 milligrams, but has some microscopic hematuria. Microscopic hematuria plus proteinuria, or a proteinuria of more than 1 gram, then you must do a renal biopsy, right? If there is membranous changes, then the patient can have a good prognosis. But when the patient is having some crescents, then the prognosis becomes worse. Okay, when you have renal lupus, when you have lupus nephritis, very, very aggressive immunosuppression is needed, and you must get the disease under control immediately so that the complications are avoided. The complications are avoided if you treat it very, very fast, right? So what are the classes of lupus nephritis? Right, what are the classes of lupus nephritis? So there are basically 5 classes. So there are basically 5 classes. 5 classes are there. So what is the first class? This is minimal mesangial lupus nephritis. Minimal mesangial lupus nephritis. That means there are some immune deposits in the mesangium. So in the glomerulus, what you have in the renal involvement, you have a glomerular compartment, you have a glomerulus, you have some blood vessels and some tubules, right? So in lupus nephritis, what happens? The tubules are not affected much. Only the glomerulus and the vascular compartment will be affected. If the vascular compartment will be affected, especially antiphospholipid syndrome, what will happen? There will be some clots. So thrombotic microangiopathy will be there. But when the glomerulus is involved, you will have glomerulonephritis. So among the glomerulus, you have few compartments. You have capillaries, you have endocapillary cells, you have some mesangial cells in between the capillaries. Okay. So all these are the components of the glomerulus, right? So what happens in minimal mesangial lupus nephritis? There will be some mesangial deposits in the mesangium. Immune deposits in the mesangium will be there. So this is called minimal mesangial lupus nephritis. The second one will be mesangioproliferative lupus nephritis. There's mesangial, mesangial cells will be there. Mesangial cells will be hypercellular. There is proliferation of the mesangial cells as well as some immune deposits in the mesangium. So first is minimal mesangial, second is mesangial proliferative. The third one will be focal lupus nephritis. Third one will be focus lupus nephritis, focal lupus nephritis. The fourth one will be diffuse lupus nephritis. Fourth one will be diffuse lupus nephritis, right? And the fifth one will be membranous lupus nephritis. Membranous lupus nephritis, I told you, this has somewhat a good prognosis. Somewhat a good prognosis. Then the sixth stage will be advanced sclerosing lupus nephritis, where you can basically not do anything. So in this stage, aggressive immunosuppression will not be useful, right? So it is first stage will be minimal mesangial lupus nephritis, mesangial proliferative lupus nephritis, focal lupus nephritis, diffuse lupus nephritis, membranous lupus nephritis, or advanced sclerosing lupus nephritis. Okay, all these are the 6 grades. So in this, you need to see something very, very important. These are wire loop lesions. Wire loop lesions. What are they? They are basically deposits. Deposits in the mesangial space. Nodules in the mesangial space. Okay, so these are wire loop lesions seen in lupus nephritis. Wire loop lesions seen in lupus nephritis. Okay, yes. So on immunofluorescence, you have something called a full house effect. Full house effect on immunofluorescence. You need to remember this term because it's very commonly found in the MCQs, right? This grading might be difficult for you initially to learn, but as you keep studying, you can get it very easily. So on immunofluorescence, you must remember this term. It's called a full house effect, where you will have IgG present, IgA present, IgM present, C3, C1q, as well as fibrinogen. All these will be deposited in the mesangium. So this is called a full house effect. All the immunoglobulins are present. So this is called a full house effect, right? So this is the immunofluorescence finding. So there is something called the SLICC criteria to diagnose lupus. So among this, you have the clinical features and the immunological features. So let's look at the immunological features first. You have a high ANA concentration. Makes sense. So you get the titers. The higher the titer, the more sensitive it becomes. Right? The more sensitive it becomes. So high ANA concentration. Then high anti-DSDNA antibody concentrations. So in presence, you need to have high anti-DSDNA antibody concentrations, but just the presence of anti-Smith itself indicates that it is lupus, right? Then positive antiphospholipid antibodies. Complement levels will be low. Then the direct Coombs test will be positive. So like I told you, autoimmune hemolytic anemia, these features will be present, right? So you need to have high concentration of ANA and anti-DSDNA, presence of an anti-Smith antibody. You need to remember the difference. Positive antiphospholipid antibodies and low complement levels and direct Coombs test will be positive. Coming to the clinical features, like we already studied before, cutaneous lupus will have maculopapular lesions, photosensitive lupus rash, chronic cutaneous lupus will have discoid rash, mucosal ulcers, oral or nasal ulcers can be there, non-scarring alopecia will be there, synovitis will be present in 2 or more joints, serositis, synovitis. Right, serositis will be there, which can be pleuritis, pericarditis, endocarditis, or myocarditis. Any of these can be there. Then renal involvement with urine protein or RBC cast can be there. Neurologic manifestations including seizures, psychosis, depression, okay, cognitive dysfunction, then hemolytic anemia, leukopenia or lymphopenia, then thrombocytopenia. All these can be present. Okay. Among this, if you have at least a total of 4 features with at least one of this and one of this, then it means that the patient is having systemic lupus erythematosus. You must have 4 features, with at least one being from the clinical criteria and one from the immunological criteria. At least one of each should be present. Along with the 3 more lesions should be present. Then you will diagnose the patient as having lupus. Or one more thing is you should have biopsy-proven lupus nephritis with anti-DSDNA antibodies or ANA. Okay, ANA antibodies or anti-DSDNA antibodies should be positive with a biopsy-proven lupus nephritis. Then you call that the patient is having systemic lupus erythematosus, right? So this is very, very important. So how do you monitor the disease course? You need to check the HP, platelet counts. You need to do, I told you, urine analysis every time the patient visits you. Serum creatinine, serum albumin, anti-DSDNA levels, complement levels, soluble interleukin levels, and urine levels of MCP1. Okay, so basically, how do you divide these lesions? How do you divide these lesions? I told you it is characterized as mild, moderate, and severe, right? So how do you basically characterize this? Mild means there are constitutional symptoms. Constitutional symptoms plus you have a skin disease plus mild arthritis, right? Mild arthritis. So in that case, you call the patients having mild SLE. Constitutional symptoms will be there, skin disease will be there, and mild arthritis will be there. Whereas in moderate, you will have the constitutional symptoms plus skin disease plus severe arthritis. Severe arthritis. Remember, constitutional symptoms, skin disease plus mild arthritis, or constitutional symptoms plus skin disease plus severe arthritis. Right. Severe disease will be when you have organs involvement, organ system involvement, organ systems involvement. Then you call it as severe SLE, severe SLE. So you need to remember the severe SLE. How are these assessed? These are assessed based on the SLEDI score. Sorry, these are assessed based on the SLEDI score. SLEDAI, SLEDI score. Okay, these are characterized based on the SLEDI score. Okay, yes. So moving on to the management. How do we manage these patients? What are the goals? You need to decrease the flares, You need to prolong the remission, and you also need to maintain the organ function, right? You need to maintain the organ function. You need to decrease flares, you need to prolong the remission, and you need to maintain the organ function. So how do you basically treat these patients? Right. So how do you basically treat these patients? So let's go to the treatment. So a patient with SLE. The patient can have a first mild SLE. Let us see how do we treat. So for these patients, what should you give? You should give steroids, oral steroids. How much should you give? 1 milligram per kg per day. So if you have a 60 kg person, then you give maximum 60 milligrams, right? So when a patient is 75 milligrams, 75 kg, you give a patient a maximum of 60 milligrams. 60 milligrams should be given. That's more than sufficient, right? 60 mg per kg, 60 mg should be given for 6 weeks, right? For a period of 6 weeks. Then you basically taper the dose after that over a period of 3 months. Over a period of 3 months, you taper the dose, right? Along with this, you give HCQ, hydroxychloroquine. Hydroxychloroquine is given to all the patients of lupus, irrespective of what class they belong to, right? So mild lupus, what do you give? You give oral steroids, 1 mg per kg per day, 60 kg, 60 milligrams for about 6 weeks. Then you taper the dose over 3 months to a low dose, lowest possible dose. And you also add the patient on HCQ, right? If the patient is having severe lupus, what will you do? You will give IV steroids, right? You will give IV steroids. How much should you give? You will give 3 doses. You should give 3 doses. How much is that? 500 mg to 1 gram pulse dosing. This is called pulsing with IV steroids. This is called pulsing with IV steroids. So you have to give pulsing, then followed by oral steroids. Again, the same 1 mg per kg per day, right? 1 mg per kg per day. Then you again taper it. But in this, you need to add a second line drug, which can either be cyclophosphamide or MMF. You can add a second drug, which is cyclophosphamide or MMF, right? So you need to give pulsing IV steroids, then followed by oral steroids. Along with that, you can give cyclophosphamide or mycophenolate mofetil. Then, if the patient is having a moderate disease, what do you do? If the patient is having a moderate disease, what will you do? First, you give steroids. Like in all, you give steroids. 1 mg per kg per day. 1 mg per kg per day. Then you again taper. But along with this, you add either methotrexate or azathioprine. Methotrexate or azathioprine. Here you have to add HCQ. In all the patients, you can add HCQ. But along with the steroids, you can add methotrexate or azathioprine in patients with moderate lupus erythematosus. In patients with severe, you add cyclophosphamide or mycophenolate mofetil. Okay. As a second line drug here, you can use belimumab. Belimumab, which is actually an anti-BAFF inhibitor. Anti-BAFF inhibitor, right? This is a new drug. We need to remember belimumab is very, very important. It is given for moderate lupus erythematosus, right? Moderate lupus erythematosus, you give this. So what happens now? You have crossed a period of 3 months, right? You have now treated the patients for 3 months. So what will you do after this? If the patient is having complete remission, you continue low dose steroids. Low dose steroids plus MMF or azathioprine. You prefer MMF more over azathioprine. If there is no response or there is partial response, then what should you do? If there is no response or there is only partial response, what will you do? If you're already giving the patient cyclophosphamide, then you put the patient on MMF. Or if the patient is taking MMF, then you change the patient to cyclophosphamide and you give that and try for some more time. And if it's still not getting treated, then this is called resistant lupus. Resistant lupus. So for resistant lupus, what should you do? You can give rituximab, right? You can give rituximab. Or you can also give calcineurin inhibitors. What are the calcineurin inhibitors? Tacrolimus and cyclosporin, right? You can give rituximab or calcineurin inhibitors. I want you to remember. So if it's a mild disease, you have oral steroids 1 milligram per kg per day for 6 weeks, then taper over 3 months. Along with that, you add HCQ also. In severe disease, you give IV pulse dosing of steroids 500 milligrams or 1 gram based on the weight. Then along with that, you follow it by oral steroids 1 milligram per kg per day. You add cyclophosphamide or mycophenolate mofetil along with that. If it's a moderate systemic lupus erythematosus, you give steroids 1 mg per kg per day. Along with that, you add methotrexate or azathioprine, right? And second line drug can be belimumab in these patients. So you treat all these patients for 3 months. If there is complete remission, you just continue the patient with the lowest possible dose of steroids along with MMF or azathioprine. You prefer MMF over azathioprine in lupus patients, right? If there is no response or there is only partial response, what will you do? You will exchange. Suppose the patient is having cyclophosphamide already taking, then you give mycophenolate mofetil. If the patient is taking MMF already, you give the patient cyclophosphamide. If still there is no response, then you call this as resistant lupus. In these patients, you should either treat with rituximab or you can give a calcineurin inhibitor along with mycophenolate mofetil. Okay, so you should give either a calcineurin inhibitor or with mycophenolate mofetil, right? Yes. So let's move on. So this is just to reiterate the points. Like I told you, the first line drug, in all the patients you will have HCQ. In all the patients you will have HCQ, right? HCQ seen and given in all the patients. Then for mild patients, for mild disease, you have glucocorticoids, orally given oral steroids. Here also you give glucocorticoids. In both mild, moderate and severe, you give glucocorticoids. That's the first line of drug. In severe, however, you give IV steroids. In severe, however, we give IV steroids. Then we have methotrexate. For mild to moderate, you have methotrexate or azathioprine. Mainly for moderate, you give methotrexate or azathioprine. As a second line drug in moderate, you have belimumab. You can use belimumab. Right. In severe patients, you can give calcineurin inhibitors or mycophenolate mofetil. In very severe cases, you can give cyclophosphamide. If none of these work, then you have to give rituximab for these patients. If none of these work, then you should give rituximab for these patients. Right? Yes. Then, if the patient is having a class 5 lupus, this is a common question found in MCQs. If you have a class 5 lupus nephritis, how will you treat the patient? You should see whether the patient is having a proteinuria of less than 1 gram or more than 1 gram. Proteinuria of more than 1 gram or less than 1 gram. If the proteinuria is less than 1 gram, then you just give the patient oral steroids plus AC inhibitors to reduce the proteinuria. AC inhibitors reduce the proteinuria. But if it is more than 1 gram, then you should treat the patient with steroids plus mycophenolate mofetil. In some cases, even cyclophosphamide will be required. Cyclophosphamide will also be required. So there are some new drugs that you must remember. Right, what are those? Aferolumab, right? First one will be aferolumab. Aferolumab. And the second one will be ocrelizumab. 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 This ocrelizumab is anti-CD20 antibody. Anti-CD20 antibody. And aferolumab anti-TNF alpha antibody. Okay, aferolumab is anti-TNF alpha antibody. Ocrelizumab is anti-CD20 antibody. So these are some of the new important new drugs that you must remember. Okay, so how to see whether the patient is having mild disease or moderate disease or severe disease? Like I already told you, what should be the SLEDI score? I'll just revise that. If the SLEDI score is between, there's a SLEDI score, something called a SLEDI score. I'll tell you this SLEDI score. This is a parameters of 24 in number. 24 parameters are checked in this. So if you have anything between 0 to 5 parameters positive, then it is called mild disease. If you have 6 to 12 parameters, then it is called moderate disease. Whereas 13 to 20 parameters, it is called severe disease. 0 to 5 it is mild disease, 6 to 12 it is moderate disease, and 13 to 20 it will be severe disease. Right? Once you treat, the drop in the number of manifestations should be between 3 to 7. If 3 to 7 points reduce, then it means that there is a significant clinical improvement. There is a significant clinical improvement will be there. Right? Yes. So mild disease 0 to 5, moderate disease 6 to 12, severe disease 13 to 20. If there is a 3 to 7 point reduction, that means there is a significant clinical improvement. There is a significant clinical improvement. Right. So this is the SLEDI score for you to look at. So all the manifestations will be there and there are points allotted for this. Right. You can see here, these are all the points. Right. So some special situations, pregnancy and lupus. Pregnancy is not a contraindication for patients with lupus nephritis. If you're planning for pregnancy, you just need to modify the drugs accordingly. And the fertility rates are quite normal. There is an increased risk of fetal loss, but still the pregnancy is quite common in lupus patients. they usually get a healthy active pregnancy in lupus patients. So azathioprine is a very, very important drug which can be used in these patients. And if you have a flare, in those times you can give prednisolone for the shortest possible time along with the HCQ. And azathioprine is a safely used drug. Immunosuppressants are secreted in the breast milk, so you should generally avoid to breastfeed the patient when you're taking these immunosuppressive medications. Okay. Yes. Neonatal lupus is also a very important question because MCQ is usually based on this. So in neonatal lupus, like I already told you, anti-Rho antibody will be present. Complete heart block will be present. Complete heart block can be present. The baby can also have some skin manifestations. So regular fetal heart rate monitoring will be advised for the patients. Regular fetal heart rate monitoring is very, very important to avoid this congenital complete heart block. Right? Yes. So anticoagulation SLE is not commonly indicated. It is only when you have a venous or arterial clot which has formed, or you have a repeated fetal loss, you have an adjunctive antiphospholipid syndrome, then you put the patient on anticoagulation. Right? Otherwise, you generally don't regularly anticoagulate the patient in SLE. Right? The prognosis is fairly good. Nowadays, we are able to treat the patients very well. But in some patients, once the complications develop, then the mortality increases. The risk for chronic kidney disease increases because of lupus nephritis, which is not detected earlier and not treated appropriately with good immunosuppression. Then the CKD can happen. CKD will progress. Right? So this is very important. Cause of death, I told you there is accelerated atherosclerosis. So the most common cause of death will be later stages, it will be thromboembolic events. But in the initial stages, it can be either a lupus flare or associated antiphospholipid syndrome, which can be catastrophic, or an increased systemic activity of the disease. Right? All these can be complications, and infection is also a very important complication in SLE. Infection can be a very, very important complication in lupus erythematosus because of the heavy doses of immunosuppression that we are giving for the patient. Right? Yes. So how do you differentiate between an infection and flare? I told you one point already. There will be leukocytosis in infection, whereas there will be leukopenia in a lupus flare. CRP will be elevated. I told you CRP will be normal, or there will be a mild increase or a decrease in lupus flare. Right? In infection, the factors like procalcitonin will be increased, whereas dsDNA will be increased, which will actually show the disease activity. Disease activity is shown by dsDNA, so this will increase in levels. And the lupus flare will show a response to prednisolone. But if you give prednisolone for a patient with infection, the infection will get flared up and the patient will become very, very sick. Right? So this is the difference between an infection and lupus flare. So another most important topic, a favorite MCQ topic for the examiners, which is drug-induced lupus. In this unit, remember some very important drugs, right? Carbamazepine or chlorpromazine. Carbamazepine, chlorpromazine, hydralazine, isoniazid, flecainide, procainamide. These are some of the drugs which are implicated in drug-induced lupus. A few important newer drugs which are implicated are infliximab, right? Infliximab, anti-TNF alpha antibodies, infliximab, and etanercept. These are also implicated in drug-induced lupus. So in drug-induced lupus, I told you the antibody which is commonly implicated is antihistone antibodies. Antihistone antibodies. Right? Antihistone antibodies. Yes. Moving on to the last part, antiphospholipid syndrome. Antiphospholipid syndrome can occur in conjunction with systemic lupus erythematosus, or it can be happening separately also. So there are basically two types. Antiphospholipid syndrome is mainly characterized by increased risk for thrombosis. There is hypercoagulability in the blood. So because of which there is an increased thrombosis. So what happens because of the recurrent arterial venous thrombosis? There can also be some pregnancy morbidity which is happening. Antiphospholipid antibody syndrome can be either primary or secondary. Right? Primary or secondary. Primary is you have a genetic predisposition to develop this antiphospholipid antibody syndrome. Secondary is an association with other connective tissue disorders like SLE. Okay, so primary or secondary. Primary and secondary. Secondary is associated with other autoimmune diseases. So what do you note in these patients? What do you see in these patients? They have a thrombogenic state. There is a high risk for thrombosis in these patients. There is complement activation. There is coagulation regulatory proteins there is interaction, procoagulant conditions will be there. So there's an increased risk of thrombosis. There is increased risk of thrombosis, right? So we'll just quickly brush through the criteria for antiphospholipid syndrome. You have something called the clinical criteria as well as the clinical criteria and the lab criteria. Among the lab criteria, you need to remember there are three important antibodies. First is the lupus anticoagulant, anti-beta-2 glycoprotein antibody. It is not microglobulin. It is anti-beta-2 glycoprotein antibody and anti-cardiolipin antibody, IgG or IgM. Anti-cardiolipin antibody, IgM or IgG. These are the lab criteria, whereas the clinical criteria will have vascular thrombosis, arterial or venous thrombosis can be there. Most commonly, venous thrombosis is seen in these patients. And a pregnancy morbidity. How do you define the pregnancy morbidity? You have three features, mainly death of a normal fetus at more than 10 weeks or premature birth of a baby at less than 34 weeks due to preeclampsia, HELLP syndrome, all those things if the patient is developing and the patient is having a premature birth at less than 34 weeks. Then more than 3 consecutive abortions at less than 10 weeks. Or there is placental insufficiency at less than 34 weeks. Yes, there is placental insufficiency at less than 34 weeks. All these are features and form the clinical criteria for manifestation of antiphospholipid antibody syndrome. Right? Yes, there is something called catastrophic APS. What is this catastrophic APS? Is antiphospholipid antibody syndrome plus MODS. Multi-organ dysfunction will be happening. So you will have 3 or more organs will be involved. Yes, how do we treat these patients? It is very, very catastrophic. Unfortunately, the patients usually, the mortality rates are very, very high. In these patients, you will have antiphospholipid antibody syndromes and antiphospholipid antibodies, and you will have more than 3 organ involvement. So what is the treatment? You do plasmapheresis for the patient. You can give IVIG, steroids and anticoagulation, but the mortality risk is very, very high. Mortality is very, very high. Right? You must remember these points. Treatment, usually you give warfarin for the patient. If there's a thrombotic given, then you give the patient warfarin, and you must maintain the INR between 2.5 to 3. You must maintain the INR between 2.5 to 3. If there's an increased pregnancy morbidity, then you put the patient on heparin and aspirin. If the patient is having consecutive abortions, then you have to put the patient on heparin and aspirin for the next pregnancy. Right? Right. So heparin and aspirin should be given daily. Yes. Thank you so much for joining in. So before we end, I would just like to ask one question. This SLE is what type of hypersensitivity? SLE is what type of hypersensitivity? Is type 3 hypersensitivity because of the immune complex formation. I want you to remember this point. It is type 3 hypersensitivity. It can be asked as a microbiology question also. Right? Thank you so much for joining.
Thank you, ma'am. Thank you so much. It was really a wonderful session, and this is a very important topic from both a university exam point of view, a commonly asked essay question, as well as from the entrance exam point of view also. So already we have covered 2 important lectures where we have discussed about arthritis. So thank you so much, ma'am, for joining with us today. And I think those who are unable to join with us today in live, kindly go through this video as well as the previous 2 videos of arthritis, so that this at the end of the completion of rheumatology, it will be easy for you to complete and attend the test and discussion. Thank you so much, ma'am, for joining with us today once again. And let's meet with you all in the next important discussion of rheumatology. Thank you, ma'am.
Thank you.